evening, everybody. I hope that you can hear us this evening. Thanks for dialing into this second set of webinars that we've been running to support you all in your roles within the care homes just now. This evening we've been joined by Jude Marshall, Libby Ferguson and Claire ONeill, and the topic that we're looking to cover this evening is how we can care for our residents during the COVID-19 pandemic. We're looking to cover how we can support their care and how that might even be how their care and support towards the end of their life if that is the case. So you again had submitted some really good interesting questions to Francis McMeekin, our Assistant Chief Officer, who's collated and compiled them for you and grouped them for the consultants and nurses to answer for you this evening. So I'm going to hand you over to Jude Marshall, because Jude's got quite a few things she thinks she can run through with you, and then we'll open it up to question and answers as we go. Okay.
Hi, I'm Jude Marshall. I'm a GP and I work mostly in nursing homes, and I've met some of you have been around some of the residential homes. So the questions were sent to us and we've kind of grouped them together. I know that at this time everybody's feeling really anxious and you're worried about things like PPE and your protection and your health and the health of your families as well as the residents. But there is going to be a video available of the doctors who did the session last week on PPE. We can answer some questions, but we're not experts on PPE. We were going to cover more caring for patients who may or may not have COVID-19 in the residential homes. One of the first questions was, will you be caring for patients with COVID-19 possibly? And the answer to that is yes, it's likely that you will be looking after people with COVID-19 at the end of life possibly. But remembering also that lots of people who get COVID-19, even frail elderly people, do improve, so it's not a definite if someone falls unwell with the symptoms of COVID that they will die of that. A lot of people, in fact the majority, do improve and get back up on their feet and get back to the way that they were before. I'm going to try and share some of the questions with the other people who are here tonight. So Libby, we were talking yesterday about managing people in the care home rather than going to hospital. Would you mind talking about that?
Yeah, sure, thanks Jude. So hi everyone, my name is Libby Ferguson. I'm a consultant at the Marie Curie Hospice in Springburn and also with the palliative care team at Glasgow Royal Infirmary. So one of the questions that come up in the submitted questions was whether patients, when they're suspected to have coronavirus, should be transferred to the acute hospital. I think the first thing to say is there can't be a blanket decision for patients in residential care homes that they should all go to hospital or they should not go to hospital. I think this needs to be an individual decision based on the person, and I think in Glasgow we're in a good position in that a lot of the patients in our care homes have got anticipatory care plans, so when that person becomes unwell, the district nurse or GP and along with yourselves will look at that individual's case and make a decision based on what benefits there might be to that person going into hospital. So with coronavirus, if someone is very frail and potentially has other health conditions, then there might not be much to gain from transferring them to an acute hospital. I thought it might be helpful to talk about what does happen when someone's dying and they get transferred to an acute hospital from a residential care home. So the reality is they'll get transferred in an ambulance into accident emergency, and when they arrive there, the doctors and nurses always try not to do anything inappropriate or do investigations that wouldn't change the management, but in A&E it can be quite hard to make those decisions, so they'll usually have blood tests done, possibly get drips put in, maybe x-rays, that kind of thing. And although the staff will try and get them to a ward as soon as possible, it might be that they're on a trolley for a number of hours before they get to the ward, and that's where my colleagues in the Royal or whatever hospital it is that they're going to will see them on the ward round and I guess recognise that the person is dying. And really at that stage there's not much in terms of medical management that's done apart from making sure that they're as comfortable as possible. And it's always a bit of a shame when you see someone in that position because you know that they're in an unfamiliar surroundings, and you know it would be nice to think that they could potentially be cared for where they consider their home with staff that know them. So I think the reality is the care that is provided in a hospital in these situations could be provided in their care home, and I think it's important that you know you've got the skills to do that. If they think there's any reversible medical issues that would be appropriate to treat in a hospital, and that's when they'll decide whether to send into hospital or not. I think it's important to say that you as the staff in the care home will know these people probably better than the clinician that's assessing them. So if you feel strongly one way or another that you don't understand why a decision's been made, I think it's important you know that it's okay to ask that question of the person that's making the decision, so that you understand why a person is or isn't being transferred to hospital. When they're unwell or from a care home, is they'll end up going to accident and emergency, where they'll be assessed by the doctors and nurses there, and they'll probably end up having blood tests, drips put in, which maybe aren't something they would necessarily need. It'll probably involve being on a trolley, possibly for several hours until there's a bed available in the ward. And then when they get to the ward, they'll be cared for by the nurses and doctors there, but the care that's provided in the majority of cases could be provided in their care home, because it's good nursing care. There might be some medication that's required for symptom control, and again we can talk a bit about how that could be provided in their care home. I think in this situation one of the concerns about coronavirus is breathlessness, and sometimes patients need oxygen, and that can be organised in the residential homes as well, and Jude can give you a bit of an update on that later on about some of the measures that have been taken to provide that. So I think it's important to know that there's no magic treatment for these patients if they're admitted to hospital. So in some ways, if they can stay in a familiar surrounding for them with staff who know them and care about them, as long as you have the support which you need, and I think that's very important that you get the support you need to manage their symptoms and feel confident that you can provide that care. I think that the best outcome would be that they could be cared for in the residential home, with potential in-reach from district nursing, A&P, specialist palliative care, whatever you need. And I think that's probably one of the key messages we'd want to leave you with from the end of tonight, is that there is support available for you if you feel that you're looking after people and you need extra support to manage symptoms and support them at the end of life.
We were going to go on to, if that's okay, is maybe focusing more on what you can do rather than what you can't do in the care home. I think the things you struggle to do maybe are the things that come to mind, but we're here to say that the things that you're doing in the care home are nursing care, supportive care, symptom control, and that's really what you would get in hospital. Claire, do you want to go through the things that the residential homes can do, so that we focus on the positives rather than the negatives?
Yeah. Good evening everybody, I'm Claire ONeill, I'm lead nurse for palliative care in GGC, and my role's predominantly in acute, and we'll often see people who are transferred from the residential units, and I'm always taken aback by how well you know your residents. When they come into an acute setting, they come with information about who they are, and it's lovely to see that when we receive somebody. It's also really important for us in the acute setting to think about how we can get someone back to the home that you've created for them. So I think we're absolutely bombarded at the moment with things we can't do. Both within our working lives and then within our home lives just now. I think it's really, really important to remember that you can continue to care for people with COVID or with suspected COVID while they remain in the residential unit really well, the same way as you look after people at the end of their life that you've cared for weeks, months, sometimes years. I noticed some questions were sent in around about something. One of them was, could you shave someone with COVID? And the answer would be yes, you can. Now,
we've already mentioned PPE, and I know that last week Dr. Carter and Dr. McConaughey gave presentations on PPE, and there's going to be videos available on how to put your PPE on and how to safely take it off again. And those things are really important for you all to be familiar with. But it is important, if you're caring for someone with suspected or confirmed COVID, you use PPE, but then you continue to deliver that care like shaving someone. You're able to provide that support, and actually for us, we're continually aware in hospital that the people we're caring for are often just seeing our eyes and they don't know us. We've actually been trying to get pictures of ourselves. Somebody brought in an instant camera. We've been putting pictures of ourselves on our PPE because the patients we're seeing don't know us. Your residents are really in the fortunate position that they know you and trust your voice, which I think will make them feel so much more reassured than they would if they were in hospital. I would just really encourage you to be confident in what you can do in end-of-life care anyway, and it's what you deliver. When you're looking after people towards the end of their life, please remember that that's something that you're able to continue in caring for these people. Most people, as Jude had already mentioned, they will recover if they do develop COVID, thankfully. However, some people will not recover and they'll succumb to that. And I think you'll be able to take some privilege from being able to look after them end of life if that does happen.
So if I can just tell you a couple of new things that are happening with COVID-19 that we've not had available before for residential homes. If you do have patients who are unwell and you're caring for them and the decision's been made that they stay with you in the residential homes, first of all, the support that's available. You've got your AMP, who you always have, who knows your patients as well, the GPs available, the GP out of hours service, the district nurses. Palliative care services have been great in mobilising support for residential and nursing homes who are under a lot of pressure. There's also the fast track service with Marie Curie, who would be able to come in and support you as well. So there are lots of areas of support. We also in the nursing homes sometimes call on the geriatricians in the hospital or phone the hospital just for some advice about how to support patients. So there's lots of people you can ask, and you should never feel alone because most of us have a service that's running 24 hours a day. So please don't ever feel that you can't phone and ask, or you can't ask for help, or you want a question answered. Where there is somebody in palliative care, geriatricians, the hospital and general practice on 24 hours a day. The other things that have changed recently are that we've put a box of medication into the residential homes of just in case medication. So it's not a full complement of the medications you might have seen used before for end of life care, but there are medications in that box for simple symptoms like pain or temperatures that you might not have prescribed for a patient, but after your AMP or the district nurse speaks to a GP, they can start those medications. There's also some palliative medicines like injectable medications that again the district nurses or your AMP can give if patients have got symptoms. The idea of having this box is to kind of cut out the middleman of the pharmacy. If someone's unwell and the whole system's under pressure, it's to have those medications there ready to start so that the patient, if they're very unwell, has their symptoms managed quite quickly. There still won't be controlled drugs, so by controlled drugs we mean medications like the medications we give to calm people down or reduce agitation, or the very, very strong painkillers that we sometimes give by injection. But these can be prescribed on an as named basis. So again, if you're concerned, you just highlight your concerns to the nurses or your GP staff, and they should be able to support you with providing that. The other thing that's coming in the next few days, and in fact we would be able to mobilise it now, is oxygen support. So that's not something we've been able to do as readily at short notice in the community, but again palliative care and the respiratory services have worked together to make concentrators of oxygen available for us. And if we're concerned that patients are very breathless or we're not managing their symptoms as well as we would like to with the medications we're able to give, then sometimes they would benefit from having some oxygen, and that's something we'll be able to provide in the residential homes going forward. So I hope that again gives you a wee bit of confidence that, you know, we're all feeling anxious about COVID-19. We've never done this. You know, before we came in here, I was telling Libby and Claire about the patients that I've looked after today and how difficult it was. In some cases, in others it wasn't as challenging, but you know, these are new times for us all, and we're all working together, so please feel that you can call on people for support. Know that the treatment that really they would be able to access in hospital, they're able to access most of it in the residential homes now, so feel confident that you're providing amazing care. I've never been anything less than impressed about the care that you've been able to give at the end of life, so please take a lot from that. There was another question which I might answer, because in my day-to-day job of GP I'm answering this question all the time, is about shielding. So not that any of you would be shielding, but if you had a family member who was shielding that you lived with at home, there was concern about what you should do. And I'll tell you a little bit about shielding first. So people who are shielding are high risk people, and the idea is that we want to keep them away from all of us, really. So even if you live with somebody who's shielding and you aren't at work, you should be trying to keep your distance from them. They should be using the bathroom, the kitchen, all these places in your house at different times from you. Ideally they would sleep in a different room from you, and they would use different cutlery and crockery until it's washed from other members of the family. So that's what, unfortunately, at the moment life should be like if you live with someone who's shielding. If you're working and you're in contact with patients who have COVID-19 in the care home, as long as you're using your PPE appropriately, you're washing your hands, not touching your face, and that you change your clothes and wash your hands when you're leaving work and as soon as you get into the house, then that's really all that we can expect. That's what the guidelines are at the moment, and that's the advice that other doctors, nurses, carers, cleaners, porters in the hospitals are doing. So what we're asking you to do is really what everybody else in the hospitals is doing. So I hope that goes some way to reassuring you. There was another question about if a patient has symptoms and was isolating for 7 days and hadn't improved, should they still be isolated? Do you feel confident in answering that, Claire?
Yes, you would be keen to get some advice round about that person if you felt they weren't improving, even before the 7 days, but certainly if somebody wasn't improving round about 7 day time, you'd be looking for GP or ANP or district nurse support just to reassess that person, to see if there was anything else happening that would influence why they weren't improving. And I would say that if they were still having symptoms of temperature and cough, or that they weren't as well as you know them to have been before, then you would continue to isolate them at that stage and certainly seek review.
Yeah, absolutely. Yeah.
So there's been lots within the hospital, there's been lots of discussion about last offices, and something I actually like to think of as our final act of care, and I'm keen to call it that rather than the term last offices, because actually we do want to care for people after they've died. So we want to care for their body as we would have cared for it when they were alive. So what the current policy around last offices is that you are able to prepare the body for the funeral director in the way that you would have if the person is suspected or COVID positive, but it's very important again to be wearing your PPE to do that, and the importance of hand washing when you take your PPE off. So the general message is that last offices can be carried out Certainly within the hospital setting, we are using body bags for bodies after someone has died. They're being transferred to the mortuary using body bags, and I imagine that's probably what the funeral directors will do.
There was a couple of other questions that we'd worked through yesterday, and we thought we would just go back through them today. One of the questions that people have been concerned about was if a staff member should be tested for COVID-19 if they're caring for a patient with COVID-19. Do you want to answer that, Libby?
Yes, I mean, I think that's been a common question with the patients we've been looking after and the nursing and medical staff who've been caring for them. So if you're looking after a patient who's got suspected or positive COVID status, then you don't need to self-isolate after you've been looking after them if you've been wearing the appropriate PPE. So I think that's an important thing to say, is make sure that you're wearing the appropriate protection, do your hand washing, these kind of things, unless you become symptomatic.
Okay. There was one area of PPE that has changed recently, and when we were talking about this yesterday, we were kind of all doing different things, but we thought it would be helpful to maybe pull that together. Libby, do you want to talk about the use of masks in this care home setting?
So I suppose one of the things with PPE that's been quite confusing for everyone is across all our settings, in the care home, the hospice and the hospital, we've been following the guidance from Health Protection Scotland, and I think what's happened just as the situation has evolved and they've had more information is that the guidance has changed. So I'm sure, like you've probably found that confusing, as what you were being advised to do 2 or 3 weeks ago isn't what you're being advised to do now. And I think that, along with everything you see in the media, can be quite confusing. So following the most recent guidance, we'd been talking yesterday about what we're doing. We're now using, if we're doing a session, which could be if you're on, for me it'd be if I was on my ward doing a ward round, I would wear a face mask for when I entered the ward and keep that on for the duration of the session. And if I was going in to see a suspected or COVID positive patient, I would don the rest of my PPE and doff it when I came out, but I would keep my face mask on for that session. So although I think maybe different settings have interpreted the guidance in different ways, I think the one message is clear, is whether it's someone who is COVID positive or not, if you're providing direct care, you should be wearing PPE, and that's as much to protect the patients from you as it is to protect you from the patients. So I know certainly the nurses and doctors I work with found the latest guidance reassuring in some ways, and they're feeling a bit safer with their mask on. But it's important that even if you've got your PPE, you remember the hand washing, not touching your face is the most important point.
There was a question yesterday about immunity as well, which again, we're not experts in immunity, but the current guidelines are that even if you suspect you've had COVID or you've been tested and found to be positive and you're back at work because you're better, there's no room for complacency. So it's not that you can say, well, I've had COVID, so I don't need to wear my PPE or I don't need to wash my hands. We would really, really encourage you to keep up with the PPE, keep up with the hand washing, not touching your face, changing your clothes when you're leaving work. Because right now we're not sure that COVID-19's not been around long enough for us to know whether if you've had it you're going to have lifelong immunity, if you're going to have immunity for 3 months, 6 months, a year. This is all still to be found out. So please, if we can just emphasise one thing, it's wearing your PPE and washing your hands is really super important. We'd also talked yesterday about the clothes that you might wear to work, and I know that you were offered polo shirts, I think, to wear. Even if you don't wear that, what we're doing in our work is we wear a set of clothes for work, and then when we leave, we take off those clothes and we change into other clothes, or we go home and we have a shower, immediately wash our hair, wash our hands, and even keeping things like shoes away from other people. And once you are going to wash your clothes, the clothes you wear to work should be washed separately. They should be washed at the hottest temperature that they can be. I think it's about 65 degrees we'd spoken about, and it's important once they're washed that they are then either tumble dried, or once they're dry they're ironed, and that's the current guidelines, isn't it, from Health Protection Scotland. So I hope that reassures you that you're doing the right thing, and that's another way that you can protect yourselves and protect your families.
For me, there was something about how, is there anything that, I appreciate that COVID-19 is so new to everyone. I was thinking about how do you, are there signs or symptoms that we should be keeping an eye out for in somebody's deteriorating condition? Because we're hearing that, and we've probably observed this for ourselves, that people can have a really rapid decline in their health. Is there any hints or tips there that you can share with us tonight?
I think our experience, which as you said, it's all very new to everyone, but from the patients we're seeing, particularly the kind of frail elderly population, sometimes the symptoms can be come on very, very quickly, and the kind of things we're seeing are maybe very high temperatures, or people just deteriorating very quickly and becoming very sleepy. And sometimes people can become breathless, but I have to say, a lot of my experience with the older, frailer population is that they're maybe becoming profoundly fatigued and with temperatures and sleeping more and not eating and drinking as much. So I think I've had more experience seeing patients who've deteriorated in that way rather than becoming acutely breathless, which is what everyone worries about. It's not to say that can't happen, and if that does happen, we want the staff to know that they can ask for help if they need extra support with that. But I think the high temperatures, the tiredness, and the very rapid deterioration is something I think with the experience we're gaining across the board that we're seeing. I'm not sure, Claire, if there's anything else you have seen on the wards or...
No, I think you're in an ideal position because of how well you know your residents to be able to pick up if you see them just spending more time in bed, perhaps eating less, and then maybe becoming if their behaviour changes a bit for them, other than just sleeping more, if they maybe become a bit more confused or a bit more agitated than they may have been previously, I think it's worth then exploring with the NPs who are in, or picking up the phone to the GP, just raising a bit of concern about someone their behaviour being a bit different than normal in that respect.
There's also another question for us that's probably is within the questions that are here, but it's also coming up, I think, in the guidance. It seems to be changing about this as well. So obviously we've got the 5 care homes, and generally speaking our staff stay within that care home to work, but there could be the need at times to move staff around. And on the other side of that, even within a unit, if there's a unit that has an area that has a particular issue or an outbreak of COVID-19 within that unit, should we be trying to cohort our staff under the one roof or in that one area? Is there newer advice or guidance that you can give on how we should be grouping our staff?
I think probably Health Protection Scotland would be the best person to ask about that, but certainly the last time I spoke to them about it was where possible if you could try to cohort your staff for that shift who are looking after the COVID positive or suspected patients versus the other staff. So if that's possible, we know it's not always possible because of staff shortages, etc., for people not to move elsewhere and for there not to be bank staff if the alternative is you don't have enough staff.
Conscious of the time as well, and that folks have got to get on with their night's duties, if you like, and that I'm really grateful to our speakers this evening for coming along to join us. So thank you very much, everyone, and we'll hopefully see you again next week for the next seminar. Thank you. Good night.
Take care. Good night.
Bye.